Okay. So I found those slides describing the syndromes. They were just slightly out of order. So we'll skip ahead to those, finish this thought, and then come back to talk about the deep brain structures. So if we had a stroke, I want you to envision just limited to this superior M3 cortical segment of the MCA or the inferior M3 segment of MCA. As I was saying, you have specific syndromes associated with each. And there's lots of sources for this. I've included one here, which describes this as specifically MCA M3 inferior division, but the whole website has different stroke syndromes on it. The UBC Neuroanatomy website by Claudia Krebs has great resources for this too. So we'll start with, and we're taking the right cortex in this scenario, a right MCA superior division stroke. You might hopefully be able to predict what deficits are involved. So primarily with the superior division of the MCA, you're wiping out a large swath of lateral somatosensory, primary somatosensory, and primary motor cortex. So you're going to have sensory and motor deficits in the contralateral, in this case the left side of the body, but generally a contralateral deficit picture, where the arms and face represented laterally on the cortex are affected more dramatically than the legs represented medially in the cortex. And so those will be prominent in the superior division scenario. You can also see that an M3 MCA superior division stroke would affect Broca's area in the dominant hemisphere. So in most people, that's the left hemisphere. So if it's on the dominant side, you have Broca's aphasia. On the non-dominant side, as it's shown here, typically the perceptive deficit is not aphasia, it's hemi-neglect. So as you'll learn later in the course, hemi-neglect is associated with the non-dominant frontoparietal cortex. And I think that's mostly what I wanted to say in terms of the superior division MCA stroke. The inferior division stroke, in contrast, if it's on the dominant hemisphere, here it's shown on the right, will result in Wernicke's aphasia. In the dominant hemisphere, it does some interesting things. It's an inability to draw, to represent drawing objects faithfully, although you know you're supposed to draw them and you can see them, and in some cases even describe them. So there's some interesting perceptive deficits that arise with this type of stroke in the non-dominant, typically right hemisphere. In the left hemisphere, a right inferior MCA stroke, Wernicke's aphasia. Yes, you would also have potentially some other deficits. The most notable clinically are visual deficits. And that arises not due to the primary visual cortex damage, but due to damage of the optic radiations that surround the caudal end of the lateral sulcus. And so you get vision, I don't want to go back too far, that's way back in the lecture, but you get visual deficits based on optic radiation damage. And so that's important to consider. We've already talked about what happens when you have a localized blockage of a deep MCA-derived artery, and that will be a specific syndrome related to the structure that's where you've lost blood flow. Here, it looks like a right loss of blood flow in the right basal ganglia, specifically the lentiform nuclei. And so that would produce not weakness or paralysis, but abnormalities in motor control, a more subtle pure motor deficit. And similarly, you could have damage to the internal capsule or the thalamus. And finally, we talk about a proximal stem stroke or an M1 stroke. And that will affect both the deep brain structures and all of these cortical regions. And so that should be clear here. We're talking about a right-sided M1 MCA stroke or an MCA stem stroke. And it should be clear to you that that will deprive all of these regions of blood, and thus producing sensory deficits, motor deficits, and language or perceptive deficits, depending on whether the dominant language or non-dominant language hemisphere is affected. Now, the ACA, most strokes, the great majority of strokes, involve the MCA. And that is simply because of you've now seen how many branches are involved and how many branch points there are in the MCA and what a large cortical territory it occupies. And so probability-wise, it's just the most likely, MCA and its branches are most likely to be occluded in stroke. The ACA stroke, comparatively, ACA strokes are relatively rare, but of course they can happen. Any vessel can burst or become occluded. So the ACA arises from the internal carotid, as we've seen, and it branches and travels anteromedially to supply everything shown in purple here. So the medial cortex, as well as the medial frontal cortex and parietal cortex, as well as the inferior part of the frontal cortex here. And it has named branches, and these supply predictable territories. For example, the pericallosal branch encircles the corpus callosum, and the callosal marginal branch encircles the cingulate gyrus, traveling roughly parallel to the pericallosal branch. And then there's frontopolar and mediofrontal orbital branches that supply this inferior and most anterior part of the frontal lobe. Now, the deficits related to ACA stroke are sort of twofold. First, because their ACA branches are affecting the medial portion of the primary somatosensory and the primary motor cortices. You have sensory and motor deficits in which the legs are affected more than the trunk, the arms, and the face. So it's primarily a lower body deficit. In the case of sensation to the genitals can be lost. Typically, it's either the left or the right ACA that's affected, and of course those sensory motor deficits in the legs and the genitals will be correspondingly contralateral. The other type of deficit you get with an ACA ischemia, seeing if my daughter's all right, good. The other type of deficit you get with an ACA ischemia is an executive function deficit. And so that type of deficit tends to present as an impairment in decision-making, risk assessment, inhibition. People become inappropriate or sexually disinhibited. They have a personality change. They're unpredictably angry or acting really out of character. And all of those are consistent with an ACA infarct that affects the most anterior portion of the medial frontal lobe. One of the most sort of interesting or insidious types of deficit that can arise from an ACA stroke is abulia. So both of those spellings are correct. And abulia is a loss of motivation. And it can be dramatic, as in you have trouble responding to a question. Someone asks you a question and you respond in 30 seconds instead of a normal 1 to 2 second delay. Or it can be much less obvious. So you just don't feel like doing anything. You're very, you have flat affect. You're very passive, and you have a reduced interest in things and activities that you used to be interested in. So abulia is a symptom, a really, really problematic symptom of mental illness. And it's not that you're not crying all day long. Sometimes when you're depressed, you just don't feel like doing anything. And that manifestation is called abulia. Abulia also occurs with progressive dementia syndrome. So, and that's secondary not to frontal lobe ischemia, but in this case to frontal lobe degeneration. And for example, patients with Alzheimer's disease sometimes just stop eating. It's really difficult to feed them because they've just lost the motivation to eat. The PCAs, or the posterior cerebral arteries, project over the cortex laterally and medially to supply most of the posterior part of the cortex. And they have named branches, for example, the posterior temporal artery, the occipito-temporal artery, and the calcarine artery. And the calcarine artery supplies the primary visual cortex. So the main deficits of PCA infarcts are visual. And sometimes this is the only symptom that someone will have. And again, it's a hemifield loss of vision that's contralateral to the affected side. Now, in terms of the posterior circulation, again, as I said at the beginning, the vertebral arteries arise from the subclavian arteries bilaterally, travel through the transverse foramina of the cervical vertebrae, and then deke medially, rostral to the atlas, into the skull vault to form and merge and form the basilar artery. Now, there's a point of vulnerability here, and there are numbered regions of each vertebral artery. The first is very proximal, near its branch point from the subclavian, and the second travels most of the cervical spine. The third part of the vertebral artery is the portion where it dekes into the skull. And I'll show you this on the table too. Immediately rostral to the atlas, it takes this almost 90-degree turn and veers medially through this atlanto-occipital membrane into the skull, the cranial vault. And in taking this turn, is really hypermobile. So in a quick, high acceleration rotation, lateral rotation of the head, this artery, this section, the third part of the vertebral artery, is stretched. And as a side note, this is in cross-section of the brainstem. So these vertebral arteries en route to the cerebral cortex, where they supply the posterior cerebral cortices. This is a caudal medulla section, and you can see that they supply large swaths of the brainstem en route to supplying the posterior cerebral cortex. And so that can have a potentially catastrophic outcome. Because not only do they, my goodness, supply the posterior cerebral cortex, they also supply the lateral portion of the brainstem. And this hypermobile portion, this third portion of the vertebral arteries, are prone to arterial dissection at the atlantoaxial joint because it has to stretch so much as it passes from C2, the axis, to C1, the atlas. So it's prone in a number of life situations. One is the right-handed Gulf swing, which is the predominant swing in Gulf. And it's the torque created at that joint in Gulf that can lead to, you can see the artery is stretched, so it's thinner at this point between C2 and C1, and that renders it prone to arterial dissection. The other place this has become clinically problematic and very clinically controversial is at high speed chiropractic adjustment of the cervical spine. And so if they're in a high speed rotation of the upper cervical spine, the head at the neck, you can also cause an extracranial vertebral artery dissection. And so this has been documented in the literature. Obviously, chiropractors don't like it, and I can only tell you that based on the data that I've seen, I do not allow a chiropractor I see a chiropractor, but I do not allow a chiropractor to adjust my cervical spine. Now, just to define, pausing for a moment, to define an arterial dissection. So arterial dissection involves structural damage to the artery, often by stretching, as is shown here, when you torque the body weight around the sort of rostrocaudal axis at this level. This is the axis in dotted line, and stretch the artery, you render its lumen vulnerable to damage. And so here what's happening is there's a tear in the lumen, an intimal rupture in the tunica intima, and that allows blood to leak into the arterial wall. And so what that does, it can either, if it progresses sufficiently, if there's enough bleeding into the artery, it can occlude that artery completely, or it can narrow the functional diameter of the artery. And that's what's shown here. As those arteries descend and merge bilaterally, you can see all of the arteries that arise, and you should take note of these. As I said, you do need to know these branches. So you have the posterior inferior cerebellar arteries that branch off, typically inferior to the cerebellum, and the anterior inferior cerebellar arteries arise next, right there. And then finally you have superior cerebellar arteries arising typically from the basilar artery. And so these arise from the basilar artery, these arise from the vertebral artery, and the Acas are a little bit variable, typically arising from the caudal part of the basilar artery, not the vertebral arteries themselves. The basilar artery travels over the anterior surface of the bulbar pons, or the basal pons, and immediately rostral to the branch points of the superior cerebellar arteries. That is when it branches and gives rise bilaterally, my mouse, to the posterior cerebral arteries, which in turn travel posterior-inferiorly to supply, shown here, the occipital lobe. And this is the calcarine artery right here, traveling in the calcarine sulcus, dividing the superior and inferior portions of the primary visual cortex. Okay, and finally, as promised, I promised you we go back to the deep brain blood supply. And so all this deep brain blood supply is sort of somewhat predictable, but also quite variable. So I just want to make a few general points about it. The first is that the lenticulostriate arteries are a general category of arteries. So they are the penetrating arteries that arise almost at right angles, traveling superiorly from both the anterior cerebral artery and the middle cerebral artery, M1. And so the lenticulostriate arteries are general. The second point I want to make is that if you go from medial to lateral, there's sort of a predictable distribution of blood supply in this deep brain region from anterior cerebral to middle cerebral, interposed in there or separated by that anterior choroidal artery. So remember that the anterior choroidal artery is the most proximal branch directly arising from the internal carotid. And so if you were to parse this blood supply medial to lateral, it roughly goes anterior cerebral, anterior choroidal, middle cerebral. Okay, and that covers most of the deep brain nuclei and internal capsule. If we isolate and just look at the lentiform nucleus here, the thalamus in red here, and the caudate sweeping over the top, you can see that there's a roughly anterior to posterior distribution of blood supply. Again, this is variable. So you want to make a reasonable conclusion about what's supplied medial to lateral and what's supplied anterior to posterior. And if you can do that with these deep brain structures, you're doing well. So for example, the anterior cerebral artery supplies the most rostral portions of the basal ganglia, and so here we're looking at the putamen and the head of the caudate, both shown in blue, as arising from the anterior cerebral artery, and specifically from the lenticulostriate arteries derived from the anterior cerebral artery, or ACA. Subsequent to that, if we move into the sort of middle of the lentiform nucleus and the body of the caudate nucleus, we're getting into MCA-derived territory. Again, it's the lenticulostriate arteries, or penetrating arteries, arising from the MCA that supply these deep brain structures. And finally, when we get more posteriorly, we're looking at the PCA, which supplies a good portion of the thalamus. And again, these happen to be called thalamogeniculate arteries because they run from the posterior cerebral artery, thalamogeniculate or thalamoperforator arteries, because both of those groups run from the posterior cerebral artery to the thalamus. And so the thalamogeniculate and thalamoperforate arteries are analogous to the lenticulostriate arteries from the ACA and the MCA. And the anterior choroidal artery comes in somewhere in here. And in this portion, you can see that it happens to supply the tail of the caudate and the posterior portion of the globus pallidus. So again, medial-laterally, it's roughly intermediate to ACA and MCA, and anteroposteriorly, it arises in more posterior territory. But this is all a bit muddy. So again, a general pattern is great if you can get that. The blood supply from the internal capsule and the corona radiata is even more muddy. So I do want you to know that corona radiata is located here superiorly, and in this dissection you can see these tight collections of axons as they coalesce or converge into the internal capsule. Now, the MCA supplies a lot of this territory, and there's inter-individual variability on the consequences of MCA stroke for this reason. Some people have more or less preservation based on the amount of circulation that's derived from the MCA, supplying these deep brain structures. And so, although we've dogmatically sort of tried to map this, the MCA often supplies most of the internal capsule. And so clinically, that's just an important thing to remember. If you want to take an approximate map, you can take roughly the same anterior to posterior approach to this, where the most anterior portion of the internal capsule will be supplied by the ACA, and the anterior choroidal and PCA supply the more posterior portions. Again, clinically, you can see that the MCA often, that's why it's shown here, sometimes some people supplies almost all of this crucial white matter pathways. Finally, a section giving you it in horizontal section again, and you can see the anterior choroidal in this representation is shown supplying some of the posterior limb of the internal capsule, the middle cerebral supplying sort of a lateral portion of gray matter and white matter that's in the deep brain, and the anterior cerebral supplying an anteromedial, and posterior cerebral supplying posteromedial. And so when you start to look at this, which is one source from Martin's anatomy, and this, which is another source from Blumenfeld, then you get frustrated because you're like, wait, I don't know which artery supplies which portion of the internal capsule. And that's because it's variable. And so it's just one of those things in anatomy that is variable among individuals and really difficult to predict. But whenever you're making an argument, as long as it's reasonable, then it's viable. For example, you might say, I would predict that the posterior limb of the internal capsule is supplied by the anterior choroidal artery, and therefore an anterior choroidal artery stroke could produce a pure motor contralateral deficit that affects the body preferentially to the face. And so that brings the lecture back full circle to that case, and hopefully that makes sense, and we can talk more about this in tutorial on Tuesday.